Diabetes. It's more than high sugar. It's a battle of hormones, energy, and the body's ability to regulate one of its most vital fuels, glucose. And when the body can't do it alone, we step in with medications. But not all diabetes is the same, and neither is the treatment. Let's set the stage. There are two main types of diabetes, and they work very differently. Type 1. Diabetes. The autoimmune system attacks, destroys pancreatic beta cells that produce insulin. As a result, glucose can't enter cells, usually in children and young adults. That's why type 1 diabetes always requires insulin, while in type 2 diabetes, cells become resistant to insulin. So the pancreas tries to keep up and eventually burns out. Type 2. Diabetes is usually linked to obesity, inactivity, family history, and it's generally managed with diet, exercise, oral meds, and sometimes insulin. Under normal conditions, beta cells in the pancreas make insulin, which helps glucose enter your cells. Alpha cells make glucagon, which raises sugar when it drops too low. Think of it like a thermostat, but for energy. In diabetes, this system breaks. Sugar builds up in the blood, causing hyperglycemia, which can damage blood vessels, nerves, and organs. But if you overcorrect, boom, hypoglycemia, and your brain runs out of fuel. Diabetes has one solution: replace the missing insulin. The insulins used in type 1 include rapid-acting insulin, Lispro, Aspart, Glulisine; short-acting insulin, regular insulin; intermediate-acting insulin, NPH; long-acting insulin, Glargine, Detamir, Degludec; and pramlintide, an amylin analog for post-meal sugar control. But these come with risks that include side effects: hypoglycemia if dosing or timing is off, weight gain from increased glucose storage, lipodystrophy from repeated injection sites. Type 2 gives us more tools because the pancreas still works for now. Metformin. Metformin works by stopping the liver from making sugar, thus improving insulin sensitivity. However, it can cause side effects like GI upset, lactic acidosis, rare, and B12 deficiency. That's why it's best to avoid it in kidney or liver failure. Sulfonylureas, that include glipizide, glyburide, and glimepiride, work by stimulating insulin release regardless of glucose level. But they have a high risk of hypoglycemia, weight gain, sulfa allergy. Glinides including repaglinide and nataglinide, same mechanism as sulfonylureas. However, they are shorter acting. They can cause mild hypoglycemia, weight gain as side effects. GLP-1, agonists like exenatide, liraglutide, they mimic incretin, thus boosting insulin and suppressing glucagon. Their side effects include nausea, vomiting, and rarely pancreatitis. Also, it's better to avoid them in thyroid cancer or severe GI disease. DPP-4, inhibitors including sitagliptin, saxagliptin, linagliptin, allogliptin. They work by blocking GLP-1 breakdown. Their side effects include infections, joint pain, pancreatitis, and saxagliptin is used with caution in heart failure. Thiazolidinedione, including pioglitazone, rosiglitazone, work by activating PPAR gamma, thus improving insulin sensitivity. Their side effects include fluid retention, weight gain, fracture risk, and bladder cancer, specific to pioglitazone. SGLT2 inhibitors like canagliflozin, dapagliflozin block glucose reabsorption in kidneys, making sugar leave in urine. They can cause UTIs, dehydration, and ketoacidosis as side effects. That's why it's best to avoid them in renal impairment. Alpha-glucosidase inhibitors including acarbose, miglitol, block carb breakdown in gut. That's why they cause bloating and diarrhea as a side effect. They are contraindicated in IBD, bowel obstruction, insulin, if needed in type 2. Finally, if medications don't work, injectable insulins are used to control type 2 diabetes. To keep it simple, type 1 diabetes. Must use insulin, can add pramlintide. Oral meds don't work. No beta cells, diabetes. Start with metformin. Add sulfonylureas or glinides if cost matters. GLP-1 or SGLT2 if heart, kidney issues, or weight loss needed. DPP-4 oral alternative. TZDs if insulin sensitivity is key. Add insulin if everything else fails. Each anti-diabetic medication has its purpose. Some mimic hormones, some block sugar, some just help the pancreas do its job. But the key to treatment is understanding the type of diabetes, the patient's health, and how each drug works inside the body. If this helped untangle the web of diabetes treatment, give it a like and subscribe. And if you've got a topic you want broken down whiteboard style, drop it in the comments